which time zone you're joining from. So I would like to extend a warm welcome to all of you on the platform of APPNA MERIT Research and Innovation Landscape in Pakistan webinars. And these webinars we are doing every 2 weeks on Saturdays at 12 p.m. US Eastern Time, which is 9 p.m. Pakistan Standard Time, and then respectively any other time zones you're joining from. So as I'm sure most of you know, APPNA is the Association of Pakistani Physicians in North America, and the Merit Healthcare Subcommittee is the medical research innovation, is the medical education research, international training and transfer technology subcommittee of APPNA. My name is Dr. Sarfraz Hasni. I am the Director of Lupus Clinical Research at the National Institutes of Health in Bethesda, Maryland. And I'm a clinical researcher and physician scientist. And I'm joined by our panelists, Dr. Syed Uzair Ghani, Dr. Mohammad Akhtar Hamid, and Dr. Jabeen Fayyaz, who are joining from, in fact, all three are joining from Toronto, and they will be providing their comments at the end of the webinar. Before I introduce our speaker today, I would like to say a few things about some of the housekeeping things. One is that we have created a resource library for all of you. It's called the Digital Library, and we have all the clinical research and relevant resources on that WhatsApp group. So if you have not joined, we will put the link in the chat, and you can join that, which is a valuable resource for anybody who would like to go back and get and learn about clinical research and related topics. The other thing is that all of the recorded, and very soon after the recording, we would have them available for you, both on the WhatsApp as well as on the YouTube channel. So you can just go and view. If you would like to revisit, you can. Those are some of the houses, and with that, Dr. Basharat is an experienced medical specialist with a diverse background in sponsoring public, private, and NGO sectors, and he has also played a role in the Ministry of National Health, Provincial Health Department, as well as WHO, USAID in Global Fund for AIDS, TB, and Malaria, Bill and Melinda Gates Foundation, Royal Tropical Institute of Netherlands, Indus Hospital and Health Network, and Diabetes Center Network Pakistan. He has extensive exposure as a technical lead for National Program for Family Planning and Primary Health, EPI, National TB, HIV, AIDS, and Malaria Control Program. His areas of expertise include strategic planning, environment and climate health, and there is a long list of accomplishments that I can just go on and on. But obviously today we are waiting to hear from him and learn from him and his expertise. So with that, I hand it over to Dr. Basharat Khan. And Dr. Basharat, thank you so much for taking time out of your busy schedule. The floor is all yours. Thank you.
Thank you, sir. First of all, I would like to pay my thanks to the organizers of this Association of Physicians of Pakistan, of North America. And secondly, I'm really excited and honored to have this galaxy of experts around us today. And I'm really feeling good and delighted to talk on this strategic planning today's presentation. So the topic of today's presentation is the strategic planning in public health, the Diabetes Center Network Pakistan, a case study. I have tried to actually customize my slides according to the time given to me, and I try to be in time for that matter. So should I let me share the slide now?
Yes, please.
Sure. Hopefully you can see the slideshow.
Perfect.
Thank you so much. So as you can see here, we are today we will be talking on the strategic planning activity, particularly related to the diabetes in Pakistan. So once we talk about the diabetes, let me have this slide first for you, that usually the health related matters in sustainable development goals are limited to the SDG 3 component. But unlike that, the diabetes is, you can see, spread over more than, five different sustainable development goals that talk about diabetes. And diabetes, the topic of diabetes is interwoven among all these five components of the SDGs. That is first SDG, the no poverty. So it has a relationship with diabetes. SDG 2 says zero hunger. Uh, SDG 3 is good health and well-being, of course, that is directly related. But SDG 4, quality education, and SDG 10, that is a reduced inequality, is also related to the this topic which we are talking today, that is the diabetes. So before embarking on the strategic planning exercise, with what we did in the recently, let me have a quick look of the prevalence of the diabetes in Pakistan. And you can see here that over the last 6 years, you can see right from 2019 till now, you can see how the prevalence of the diabetes in Pakistan has been increasing. It is increasing to a sort of disproportionately high level of diabetes in Pakistan. In 2019, it was ranking 8th among top 10 countries with impaired glucose tolerance, while it ranks 4th in 2021 among top 10 countries with undiagnosed diabetes. But now in 2024, Pakistan is ranking first among top 10 countries with IGTs, and you can see that the rapid influx of the prevalence of the diabetes in Pakistan from this. Another this statistical data shows that the Pakistan ranks first among the highest comparative diabetes prevalence, that is 30.8% in Pakistan. It ranks high for the high proportion of death under the age of 60s. It is more than 7 million of people in Pakistan have diabetes, which is expected by the year 2025. 11 million adults in Pakistan have IGT, that is impaired glucose tolerance test, which is at high risk of developing type 2 diabetes. 6 to 7% of the people with diabetes in country suffer from diabetic foot problems, whereas 26.9% of the adults with diabetes in Pakistan are undiagnosed. So, in summary, if I can say that from these figures, that every third person in Pakistan has the potential risk or is suffering from the diabetes in Pakistan, which is quite alarming. Uh, Public health issue in Pakistan in the non-communicable disease sector. So there's again a projection of the prevalence of the diabetes in Pakistan. We have a quite say the data available to us with is up to 2022, and the rest is the extrapolation of that data to up to 2023. And you can see that extrapolation says that every year we are having almost 1.9% of increase in the prevalence of diabetes annually in Pakistan. Now I come back to a brief intro, a few slides about the Diabetes Center. Diabetes Center has been acknowledged as a center of excellence in diabetes care, and that has been registered as a and certified by Pakistan Center of Philanthropy. This is the TDC charter. TDC, we would abbreviate the Diabetes Center as the TDC. So I would use the word TDC instead of the Diabetes Center. So the mission states to be recognized as the global leader improving the lives of people with diabetes. The vision says the world without diabetes and its complication. The values are, of course, quality service, sustainability, teamwork, integrity, and compassion. The goal is reduction in diabetes-related morbidity and through the uh, reduction in diabetes-related mortality and morbidity. Approach is multi-pronged, holistic approach to the diabetes care and prevention. So the next one is about the TDC scope. The TDC scope is a rapidly emerging organization in Pakistan to provide highly specialized diabetes facilities under one roof. TDC as a custodian of multidisciplinary approach towards the quality assured uh, comprehensive diabetes care, integrating all disciplines. As you all know, that the diabetes engage all the disciplines I mean, as a sort of multi-organ disease. It includes medicine, surgery, cardiology, nephrology, ophthalmology, pathology, psychiatry, physiotherapy, dentistry, podiatry, and endocrinology, etc. So diabetes center as a specialized center is equipped with a state-of-art in and outpatient department and a purpose-built intensive care unit, etc. It has the availability of panel of teaching faculty both from inland and abroad. So here, this was a brief intro of the scope of the diabetes. And the Diabetes Center has a global profile in UK, US, and Australia as a registered entity there in these countries. So, the TDC, that Diabetes Center, is partnering with the NCD Alliance and the WHO at the same time with the community and stakeholders in Pakistan also, you can see very well. Now I come to the topic of the day, that is the strategic planning exercise that underwent in the history of Diabetes Center in a very comprehensive manner this year. So let me first introduce you about the strategic plan. What is a strategic plan? How it basically how it is used as an enabler and a tool for the advocacy. Strategic plan is the key organization document translating its vision and mission into goal and objective through a tactical approach, reflecting the fullest expression of demand with activity-based costing to be used as an advocacy tool presented to the donor governments to attract funding for the unfunded gaps. So usually it is used as an advocacy tool to seek the political commitment and to cover the unfunded gap. Carrying this spirit, we have translated all this spirit of the strategic plan into the forthcoming slides. You can see. So the audience of the strategic plan for the diabetes in Pakistan were the healthcare providers, the public and private stakeholders, the board, donors, and managers of the diabetes center network, researchers, and people suffering from the diabetes, most importantly. The guiding principles, as you can see, were the person-centered care and self-management. This is the most important a principle on which this strategic planning was based. Reduction of health inequities, of course, digitally supported health education, collaboration and cooperation to improve health outcomes, coordination and integration of the diabetes care, measurement of the health behaviors and outcomes. And lastly, but not the least, the use of AI-based solutions for the diabetes management. The methodology adopted to develop this strategic plan was the multi-stage, broad-based consultative approach adopted through a technical working group, engaging all relevant stakeholders in the country as well as the board members during the process. The process was actually to review of the international literature on diabetes care available, a review of the WHO, GDF, and IDF on diabetes, a review of the SDGs relevant to the diabetes, the review of national guidelines on diabetes management, review of the TDC structure and functions, and interaction of the board members and TDC staff. So none of the stakeholders were left and everyone nationally and internationally will consult it, whosoever will were available to us. The architecture you can see here, this is a standard architecture of strategic plan. As I have been certified from the WHO training center Reddit in Italy. Regarding that, I got training in 2013. So this is a standard architecture which we use for any strategic plan. The core plan that includes the situation analysis, that includes the SWOT analysis, gap analysis, and the goals, objective, and interventions. Whereas the operation plan includes the the interventions followed by activities and sub-activities and costing divided into different, timelines in a year, in quarters, in a year, and if it's a 5 years plan, so every activity would be divided into the monthly segregation of the operational plan. The operational plan is followed by technical assistance plan, that do we need a technical assistance from the country or out of the country for this strategic plan to be implemented in its own spirit for the diabetes care in Pakistan. That is followed by an M&E plan, and from M&E plan we mean that how we would monitor the progress and performance of this core plan implementation in Pakistan for the diabetes. And obviously that includes certain selected KPIs and in line with the international KPIs for the diabetes care and management. Their definition, their measurements, their denominators, numerators, and the frequency of the measurement of those KPIs. And finally, the risk mitigation plan, that do we need a sort of some help in case of some untoward incidents that may hamper the smooth implementation of the strategic plan for the next 5 years. For example, there could be funding constraints that could be encountered during that process. There could be some healthcare emergencies like pandemics. As you know, that previously we had the COVID-19 and we had to redefine all the strategies during that period. So we have to have this lot many things in mind, some disasters, some risks, pandemics, or some delays related to funding or some other issues for the smooth implementation. So we have to have some risk mitigation or contingency plan in hand to actually implement all those areas what we are planning to do. Next is the building blocks. You can see here standardized strategic plan includes a goal followed by strategic enablers, the strategic areas, service delivery areas, and then finally the objectives to be accomplished. So here in the case of the diabetes related strategic plan, the goal was reduction in diabetes related mortality and morbidity at the TDC network in Pakistan. The strategic enablers, usually those are the internal organizational enablers that can lead, guarantee that strategic plan to be implemented smoothly. So the leadership and governance is the topmost enabler, followed by the workforce, the monitoring evaluation system in place, the financing and infrastructure, partnership and networks, and the strategy in per se. That is, the strategic document should be there. And strategic document in this case is the strategic plan. All these blocks are the strategic enablers for that organization, for the TDC. And strategic areas, you can see the areas which we considered while developing the strategic plan were the first was the access to the diabetes care and prevention. The second area was the aversion of the complication and disability reduction. Third area was the advocacy, research, and innovations. The fourth was academics. Fifth was alliance and the partnerships. And the final was the addressing comorbidities, which is though last area, but it is very important to actually integrate the communicable diseases and non-communicable diseases in Pakistan, which is quite, at the moment, there's a dearth of this integration at the moment in Pakistan. So these are the 6 strategic areas. The service delivery areas, as I mentioned, were, you can see from here, these rows showing the levels and the columns shows the area, service delivery areas. So you can see here that there are preventive areas for the diabetes. There are the health promotion areas for the diabetes care. There are innovative areas in diabetes care, collaborative areas, curative, palliative, rehabilitative, and finally the emergency response. So level 1 includes the prevention area, preventive, promotive, innovative, and collaborative. So you see that population screening, counseling, referral, uh, both outreach through the telemedicine or telemedicine consultations is an area which we have to focus on for the prevention of the diabetes in the community. And secondly, the health promotion says that we need to have some community diabetes educator, podiatrists, certification of the healthcare providers, public awareness, like seminars, walks, symposia, social media activities, obesity prevention program, which is also a very important area in the prevention of the diabetes, and of course, lastly, the smoking cessation programs. And under this level 1, we do have the AI-based solutions regarding some interventions relevant to the prevention and treatment of the diabetes, of course, and advocacy for the key stakeholders in the country, and of course the research work regarding the diabetes care in Pakistan. And in collaborative, we have to have multilateral technical and financial partnerships, uh, reaching out to different stakeholders in public and private sector. The gray area, which you see, level 2, that describes the curative approach for the diabetes care in Pakistan. That says the clinical management of diabetes. You can see OPD, lab, inpatient, OT, patient help desk, helplines. But more importantly, establishing peripheral centers linking to the diabetes center network through a hub and spoke model for this intervention. And of course, for the differently abled population, we have to think about the people who have been differently abled during the process of diabetes, or who are differently abled before, suffering from the diabetes. So we have to think for the some curative, special curative interventions for those population. And of course, lastly, the marginalized population. When we say the marginalized population, we mean to actually focus on the underserved populations and underserved communities in Pakistan to focus on this diabetes care. The level 3 says, first of all, the palliative care regarding the eye care, foot care, kidney care, and cardiac care, and the rehabilitative care for the people suffering from the diabetes. That describes the mental health, sexual health, and physiotherapy interventions for those people. And lastly, level 4 says the emergency response. In case of any pandemic, in case of any humanitarian disasters and risks, we need to have some preparedness to take care of the people suffering from the diabetes in Pakistan. So what would happen when we would be able to actually translate all the strategic plan into action? So we till the year 2030, we envisage that we would be having 74,000 new people with diabetes registered and treated in Pakistan through this approach, and 30,000 women with diabetes will be managed. 220,000 consultation will be provided during 293,000 follow visit at the diabetes center network in Pakistan. And especially, I would talk about the type 1 diabetes, that 2,800 people with diabetes will have access to insulin treatment and blood glucose self-monitoring. Whereas we will be conducting more than 1 million clinical lab tests to actually evaluate and for evaluation and follow-up of these people suffering from diabetes and visiting at the diabetes center network. And 160,000 people in high-risk population will be seen. From high-risk population, when we say the high-risk population, we mean to say, first of all, the household contacts of the people suffering from diabetes. One, the elderly people, the women, the children, and all these high risk population would be addressed through the interventions, though as envisaged in this strategic plan. So the trend over time, you can see here the top 6 indicators. These top 6 indicators are internationally accepted indicators in globally, and you can see that over the year we would be actually demonstrating a gradual rise in the improvement and the number of registration, the number of care provided to them, diagnosed, treated, and having a sort of a good control of the glycemia and the hypertension among the people suffering from diabetes. So the first indicator is the number of people with diabetes registered at TTC network. The second indicator is the number of people with type 1 diabetes diagnosed and treated at TTC network. The third is the number of people with type 2 diabetes diagnosed and treated at TTC network. That is followed by the people with diabetes having good control of glycemia and hypertension. And finally, people with type 1 diabetes have access to affordable insulin treatment and blood glucose self-monitoring. What would happen when we will be able to address all these outcomes successfully? We would be able to actually decrease the incidence of people suffering with diabetes in Pakistan. We will be able to address the complication aversion related to people with diabetes in Pakistan. And ultimately, we will be adding value in reducing the mortality of the people suffering from diabetes in Pakistan. This is all from my side, and thank you so much. Open for the questions.
Thank you so much, Dr. Basharat. That was very insightful and definitely help us understand the strategic planning in the Diabetes Center Network in Pakistan. So we'll open it up for our panelists for their comments, and then we'll go to the question and answer. So Dr. Zair, please take it away.
Thank you very much,
Sure.
Dr. Sarfraz. Thank you very much, Dr. Basharat. Wonderful and great presentation, very well substantiated with the data. And generally, you know, we see the program, particularly the public health program, they are not very well documented or substantiated by the outcome, and the level are very, very interesting. And some of the figures are extremely alarming. So we are going to start from the panelists, but I have a just quick question that Professor N.M. Bhatt from Islamabad is inquiring about the center, diabetes center in Islamabad, and the contact person, which you can later write in the window, the chat box. But first of all, let's invite Dr. Jabin to have a comment. And you know, she is a frequent traveler to Pakistan. So what's her feeling? Yes, please go ahead, Dr. Jabin.
Yeah, thank you, Dr. Basharat, for providing such a context. Definitely being a PAM person, I'm more away from this kind of disease pattern and public health kind of initiative. But I think what I learned is that when you are implementing a program, how much preamble preparation is needed. And you also demonstrated that such things are doable by a collective effort, by collaboration. And then how can we link it to the patient level outcome, which is impacting the population? So I think that was a huge learning from me. And I think a lot of diabetes we are seeing in pediatric patients as well. So I did not get a sense that whether this include only type 1 diabetes, like what is your population makeup? makeup of, but still it is a good exemplar and case study to replicate. And we all as healthcare professionals can collaborate together to bring that kind of impact. That is what I'm getting. I learned so much. Thank you for doing this amazing work.
Thank you.
Thank you so
Now
much,
over,
Dr.
yeah, Dr. Professor Akhtar, you know, you have some clue and you may be privy that in certain areas of GTA, which is the Greater Toronto area, where there is a large population of South Asian, so the incidence and prevalence of um, chronic disease or non-communicable diseases is different from the other Canadian, and you have you are part of a big health network. So would you like to share your feeling and thoughts about this intervention?
Thank you, Dr. Uzair, and thank you, Dr. Khan, for such a wonderful presentation. It's kind of an eye-opener for me that at least Pakistan is standing rank 1 of something rather than, but at least we're proud that we are ranking 1 now instead of ranking at the bottom. But it was sad to say that the diabetes is really getting into our skin, and that we are such a huge population. And we are such a nation which has poverty lines. We are a lot of people, or good percentage of us is below the poverty line. And then having a diabetes along with that is also for me is a mind-boggling in terms of how this is possible. In terms of Pakistan, being a pediatrician and also has worked in some diabetic centers in pediatrics in UK as well as here. I do see that the rise of type 1 diabetes, which is already there, but the rise of type 2 diabetes in children are quite, approaching very fast. The one thing I would like to ask you, what is the one or two most common reason or common cause that the Pakistanis, it led to Pakistan to rank 1 in diabetes. Number 2, if you see I saw the preparation of your the diabetic center, how you want to tackle it. I mean, it's really amazing that a country like Pakistan is managing such wonderfully that we are trying to get things done in a very systematic way. But I don't think so. It would be enough seeing the gravity of the problem. But yes, kudos to you and your team who has done such a wonderful systematic setup, which can help. I don't think so it's eliminate, but it will help to elevate some part of it. In Canada, in terms of this, setup is very simple. I mean, we stopped seeing any diabetic patient in emergency department nowadays because it's not that totally stopped, but the presentations used to be a lot. Like every now and then we used to see the DKA coming to us, but now because of the network with the setup, they had diabetic nurses in all around. The patients with diabetes, they can get immediate help through the phone or through their linkages around their community. And so they don't come up with a DKA setup, or only, and usually we see that on the newly diagnosed diabetes they come. But again, the relapse of diabetes is less and less. The complications are not as huge as we are seeing in our Southeast population. Scarborough is another area where a lot of Southeast Asia populations are there. Mississauga is another area in GTA, Greater Toronto area. We see that a mix of illnesses, which is more privy to our back home population, including TB. So my question to you again, I'm trying to take, I don't want to take too much time. Could you be able to highlight what are the one or top 2 reasons which is causing this, havoc of diabetes in Pakistan?
Thank you, Dr. Akhtar. Thanks for the enlightening remarks and the question. Yes, we all know that we understand the culture of the country, that there is a lifestyle changes, actually that are impacting the emergence and prevalence high for the diabetes in Pakistan. One is the dietary habits, of course, and the second is the sedentary style coming into the this our culture and society. So these two things, I mean, uh, these are the actually the most important factors contributing towards this emergence of the diabetes to a such high alarming rate. Uh, and this is we have seen that we as a country, we are not very much now conscious about the dietary intakes, the counseling centers. We don't have the counseling centers for the overall communities to guide and to advise them on the dietary things, dietary habits. And secondly, the lifestyle, sedentary lifestyle, that is the physical inactivity I would refer to, especially coming into it, the online culture, the I say uh, the people are getting food at home without taking any effort. Even they could burn some calories to go out of home and to spare to take food out. They are now actually surrounded in their own homes, and the modern culture is actually providing them food at their doorsteps without spending a single calorie. And at the same time, we are taking foods, we are curtailing the physical activities. So these are, to me, basically these are. And of course, the cross cutting is maybe a stress, and you as a physician, you know better than me that stress is again a contributing factor, is a cross cutting contributing factor towards it. So I would refer these three factors to for this emergence. Over to you.
Thank you,
Thank
Dr.
you.
Javed. Before moving to Professor Sarwat Hussain, I have a quick question. You know what I learned, particularly like 6 months to 1 year ago, there was acute shortage of insulin in Pakistan. And as of today, which is the mainstay of treatment and management of diabetes, so the supply chain issues and the regulatory issues and the pricing issues, even the basic plain insulin and the some varieties of insulin, they were in acute shortage, and that remained for good 9 months. So my question is, are you going to develop some paper, something for the policy intervention, at least to look into these shortages and manage the supply chain, particularly about the insulin? Globally, there are just a handful of organizations which are producing the insulin, and locally in Pakistan, I think there is one or two companies which are only packaging the insulin. So again, there are two main players, Eli Lilly and another one, who are really bringing this technology. So it's a huge project. So do they have a teeth really to go and apply and ensure the supply chain or the regulatory intervention at the policy level to make it a point that there should be a continuous, uninterrupted supply of insulin? And then I'll move on to Professor Sarwat Hussain. Yes, Dr. Bishara.
Thank you, Dr. Zair. It's a very valid comment what you made actually regarding the supply chain, uninterrupted supply chain of the insulin in Pakistan. And let me reiterate that this is basically an issue related to the government and the government functionaries actually who are engaged in regulating the insulin production or insulin import and onward distribution to the public sector institutions. As far as TDC is concerned, the Diabetes Center Network is a private sector entity, a specialized institution, and luckily and fortunately, we are not encountering any sort of shortage of the insulin. I mean, regarding our demand for the clients, for our potential clients for the insulin. But as far as the countrywide issue, you are very right that we have to have this document. We have addressed this insulin shortage in this document, and of course, we also plan to reach out to the government functionaries that how this supply chain of the injectable can be maintained at the country level. But we, as a private sector entity, only request them to seek their buy-in for the management of this insulin at the country level. For us, for the TDC, for the private sector network, we don't encountering the problem at the moment. Over to you.
Okay, thank you. So now over to Professor Sarwat Hussain.
Very quick question, Ji. Thank you,
Yes.
sir. Very, very quick question. What is being done regarding education, public education, and education directly to the public and through the physicians and through the parents, so especially for children?
Sir, thank you so much. We always, I mean, rank the researchers the highest one because they are the people who have an eye on the ongoing issues. And you are very right in saying that what we have done or we are planning to do basically in the field of educating the community at large, and not only to educating the community as well as to the healthcare providers. I mean, so basically, we have two-prong approach for this that has been translated into this strategy plan. One for the community, we do have a very sort of, I would say, very objective-oriented health education department at the TDC network, which actually used to educate not only to the patients, but we do two things. We try to screen out to the people who are the household contact of that person suffering from the diabetes. So all those household could be potential or pre-diabetic people. So one approach is to actually screening all those people, and second is to ask them to come to us for a health education session. So if you visit at any point in time the diabetes center, we have a sort of purpose-built area for the health education of the community. And secondly, we are now introducing 4 certification programs for the healthcare providers. Those will be affiliated with the Health Services Academy in future in Pakistan for the patient education counseling, for the podiatry, foot care, for the eye care, for the kidney care. So we are introducing all these programs, short certification programs for the healthcare providers, right from the paramedics, the nursing staff, the GPs, the physicians overall, and as well as the healthcare allied healthcare professionals. So all those would be addressed through this intervention. So, but having said that, we understand that this is would be a very limited scope. So how can we expand this health education program, a structured health education program integrated into a primary healthcare network? So this is our aim, to actually address this with the help of the government. And you know that the primary healthcare network is under the government. So we have to reach out to the government to inculcate the health education programs in the primary healthcare setup of the country. Over to you, sir.
Dr. Khan, just another adding up a quick question. I mean, you rightly said, and Dr. Sarwat is also saying that awareness and education always played a pivotal role in any chronic illness. And the more we talk about it, the more we teach and make people aware, it helps. in Canada, I mean, I know that in Pakistan it's 30 percentage or more. In Canada, it's roughly around 10% people living with diabetes. Like every 1 in 10 person has diabetes here, and if you add type 2 diabetes, it may increase it. The trend we see in Canada that the northern provinces have a very low rate of diabetes, while the southeastern provinces has a higher rate. Is there any particular trend in Pakistan you have observed?
Yeah, you're right that there are some geographical variations or some ethnic variations. Those exist. Maybe similarly in Australia, those variations. When I was reviewing the literature, I saw those variations across the globe. But unfortunately, in Pakistan, we at the national level, I would talk, and then I will come to the TDC level. At the national level, at the country level, we are not having very good quality data regarding the prevalence of the diabetes and the uh, I mean prevalence of the diabetes at the subnational level. So this is an area that need to be tapped and need to be addressed by the policymakers at the country level. Now I come to the TDC level, that we at the Diabetes Center Network are establishing our institutions in major areas, major cities of the country like Islamabad, Lahore, Karachi, Muzaffarabad, Peshawar, and likewise. So in these areas, we do have a sort of dedicated research center associated with the Diabetes Center Network. And this year we have submitted around 10 abstracts to the IDF for the upcoming IDF activity. So you can well understand that research is a very much embedded in our every sort of TDC network institution. So what we research and what are the research topics we are adopting? This is one of the areas that we need to have the geographical variations regarding the patient visiting to the diabetes center network and looking into the trend or pattern of the diabetes. So this is an area that would be definitely accounted for, and we would. But you see that the denominator for the prevalence is the country population. So we cannot, in a limited scale, we cannot comment or we will not say that, okay, this patient coming from this area is maybe having, because we don't have that big sample size to comment justifiably on that. So I would urge that we need to have a sort of countrywide prevalence survey for the diabetes that would actually disclose us regarding the subnational prevalence of the diabetes in Pakistan. Over to you, sir.
Thank you, Dr. Basharat. So we are so fortunate that we have from the policy side Professor Zulfikar Bhutta, who is quite instrumental and been engaged with the public health for the last many decades from Pakistan, monitoring the sustainable development goals and all those things. So may I request Professor Zulfikar Bhutta really to comment about the the validation of these statistics and in the sustainable development goals, how much diabetes is having a weight over there. So can you unmute Professor Zulfikar Bhutta? Waleed, can you ask somebody to give him a mic, please?
I think he has to be moved to the panel list.
Yeah, so I have requested whosoever from the management side, can you request Professor Bhutta to the panelists? In the meanwhile, I have a couple of questions from the participant. So the first question is the role of genetics. So on both sides, subcontinent India or Pakistan, invariably, particularly some part of Punjab, we have the common genetic predisposition. So is there any difference in prevalence in India and Pakistan? So I look forward to that. This is the question. And another one is the training of all the healthcare carer for the diabetes? So these are the two questions to Dr. Professor. Basharat.
So thank you, Dr. Zaid. Sorry, I at this moment in time, maybe I wouldn't be able to comment regarding the prevalence of the diabetes in India compared to Pakistan. Basically, because of the fact that none of the countries did have their prevalence survey conducted in the recent past. And once we have, and these are all the figures provided to us by the IDF, by the WHO, and by the other global organizations. So, but at the same time, we say that with the referring to the genetic predispositions, I don't think personally that there is much difference, cultural or the differences in regarding their diet habits, regarding their lifestyle, activities, regarding the stress levels. So physical inactivity, diets, and eating habits, they are more or less can be contemplated between the two countries. So I would, it is just a comment. I'm sorry, I would not be able to give some evidence for that. Maybe, and of course, because of the dearth of the evidence based on some prevalence in India or Pakistan, at the moment, I may not be able to comment for this likelihood of the prevalence of India in Pakistan.
Sir,
And
I have a
secondly,
quick question. Sorry, go ahead. Go ahead. Sorry.
Please.
Yeah, my question is.
My second comment was regarding the question of Dr. Ozair, which he asked subsequent to the first question. I couldn't get to that question honestly, regarding some care providers.
So that relates to the training across the board to all the healthcare personnel to be trained to diagnose and to create a support system for the diabetes. So we quickly move to another question from Professor Rizwan Hashim. So his question is, what are the priorities with the research framework at TDC?
That's a very good question. Thank you so much for the question. Basically, as I told you, that we are providing care in all the domains related to the diabetes care. So, you can see that right from the foot care, eye care, so every sort of organ related issues are there under the umbrella of TDC for the aversion of complications, for the prevention of the complications. And similarly, the research topics are also, focused on those areas. We have done, as I told you, that this year we have done researches on all the areas related to diabetes, and we have also submitted the abstracts to the IDF this year. That all the areas regarding the diabetic complications are covered. So much so that we have also covered the dental health component of the diabetes in the research. We have covered the eye care issues related to diabetes in those research activities. So we let me mention at this point in time that we do have a dedicated research unit which is operating in TDC, and luckily I am the custodian of the supervisor of that research unit in the TDC, and that researchers are actually working in my unit. So I completely understand that what type of researches we are conducting, and not only to that operational researches, but we are also conducting clinical trials of different effect of different medication or different regimens for the diabetic care in at the TDC. Over from my side.
Yeah, Dr. Khan, just a quick question: how our children of Pakistan is doing in diabetes? if I say from Canadian point of view that every 1 out of every 330 children are living with diabetes, like a 0.3%. So how is our children of Pakistan even suffering with diabetes? Is it the rise there? Because the resources are better in North America or Europe side, the lifestyle can be more sedentary here because of the resources. But back home is not as much resources that which can make you live a very sedentary life. It just, I'm trying to understand this explanation.
Dr. Akhtar, you are right. You have asked a question on which I can maybe able, can talk for quite a long time, but I would not take much time. Very quickly, I would say that we understand that we lack in many areas regarding gestational diabetes management. We don't have some very good sort of account of the data. We only have the kids and the under 19 population visiting at the diabetes center, and we collect the data and we gather that data and analyze that data. So I would say that luckily or fortunately, the number is not that much high or alarming to compared to the type 1 diabetes in Pakistan. But again, I would say this is again a sort of very sort of is a statement that need to be explored and to be supported by the evidence, countrywide evidence.
I have a quick question. My question is, sir, if I may be allowed, is that what is the role of urbanization in increasing incidence of diabetes? And the reason I ask this question is that the calorie intake and the type of food in the rural areas and the activity is more, food is different. When people become affluent, their food habits change, they become sedentary, they come to the cities, and they become happier, so they have more mithai. Does that have anything to do with increased incidence?
Of course, Sarwat Saab, you are very right that pointed out that these dietary habits among the affluent people may be considered as one of the contributing factor for the diabetes. But let me say at this point in time that we are having patients from every corner of the country, and those are the urban and rural. But I do honestly, we didn't have that much data, particularly on this rural-urban proportion, and seeing that the diabetes into it. But I would say that the people who are visiting at the diabetes center, for example, more than 6,000 people visited diabetes center during the last year in 2023, and among those, almost half of them were from the lower socioeconomic status, no matter if they were coming from the urban or rural side. So if we take the socioeconomic status as a proxy indicator, irrespective of urban or rural sort of breakup, we can say that it is equally prevalent in both the sects, both the socioeconomic groups. So perhaps we can say that it would be likewise. But my concern is that we need to have some of very good, robust prevalence survey at the country level that would answer these questions, which cannot be answered to a I would say exactness at the moment. Over to you, sir.
Okay, so thank you so much, Dr. Basharat. Sorry, please go ahead.
No, so just last request, Dr. Basharat, please write down the address somebody is asking of your Islamabad center. And with this, I over to Dr. Sarfraz for a very formal closing and a formal thanks to the speaker, please.
Okay.
Dr. Zair, I have written down the contact number, and if
yes,
the guy has seen that contact number, he can please feel free to contact me.
Sure.
Over.
Thank you. Thank
Dr.
you.
Bhutta couldn't comment. Sorry, I was just wondering.
Sure.
No, Dr. Bhutta, I think they cannot manage to give him to the panelist list.
Access.
So,
Okay.
yeah,
Yeah, but
unfortunately,
he has some very good comments and very relevant about the um, survey, and I wish we could have learned from him. Apparently, in the chat, he said that the last national health survey was in 1992. So obviously, it's long overdue. I think somebody else has mentioned about prioritizing the more tangible topics from TDC, but we try to keep this webinar within the 1 hour time frame with all the discussions. So today we had a very robust discussion about this topic. Obviously, a lot needs to be done and a lot can be said. But definitely, Dr. Basharat Khan, you have enlightened us and you have taken on the reins to a mammoth challenge. Obviously, diabetes being such a prevalent disease in Pakistan and in some of the neighboring countries. So, so this was the topic today about the Diabetes Center Network Pakistan, a case study from Dr. Basharat Khan. We thank you for your insightful presentation, and thanks to all the panelists for their commentary and their discussion, and especially thank you to all the participants for joining. And last but not least, thank you to the technical team behind the scenes. Waleed and his team always there to make sure that these webinars are run smoothly, and as well as we have the recordings available very soon. Like I said in the beginning, that you can watch at our YouTube channel or you can come to the WhatsApp group. So with that, I like to thank everyone, and we'll see you all in 2 weeks from now with another topic and another presentation. And thank you so much, everyone, for joining. Until then, take care, stay well, and Khuda Hafiz.
Hafiz,
Thank
take
you,
care.
Dr. Thanks a lot.